And it's now my absolute pleasure to welcome back Danny Altmann, Professor Danny Altmann from Imperial College in London, who's going to give us the presentation on treatment of long COVID. Danny, welcome.
Thank you. So people would have gathered, I'm an immunologist. I work at Imperial College in London, and I want to take a few minutes to talk about long COVID. What do we know? What do we need to know? And how does this lead to future treatments? So I know we have people on this call from many different countries. I'm speaking from the United Kingdom, where there was quite a sort of rapid move into long COVID clinics, although perhaps not always with the results that we hoped for, despite heroic efforts. But if we're talking about what kind of meaning clinical support could we get or do we want from long COVID clinics, some of the obvious questions to think about: who will refer you there? How will you get there? What kind of diagnostic certainty will you need to arrive there? What clinical specialties will sit in them? We've already talked, and we'll talk some more about how incredibly multi-system this disease is. And if we're talking about many millions of cases across the world, who are these staff and where will they come from, and where and when will they have been trained? And when these people are sitting in their long COVID clinic, what will be in that clinic? What specialist equipment will they need? What tests will they apply to work out what's wrong with you? And how to deal with the fact that a person's symptoms may relapse and remit and move between needing the support of a rheumatologist or a cardiologist or an endocrinologist, or you can see what I'm getting at here. And if you put all of that together, how is this person going to work out what type of management, what kind of therapeutics, what kind of medicines will help the person in front of them? And the big scary question that we all worry about: how many years do we need to plan these clinics for? Certainly, in the UK, I think there's no particular long-term planning about it at all. And of course, we don't know whether this is a 1-year question, a 5-year question, or more. So I was asked to talk about treatment now and in the future, but I'm not terribly good at following instructions. But also, more than that, I didn't really want to get into that kind of Donald Trump kind of territory of rumors I've heard from my friends of things that have worked, or pouring bleach down people's lungs, or whichever one it was that he liked. So rather than talking about things I know that friends have got to work, I thought I could give a more usefully a kind of general talk about where the answers come from and what kind of answers we're after. So I hope that's helpful. So many months ago in the British Medical Journal, I got together with Rosemary Boyton, and we put down our kind of manifesto, really, of what we thought was needed to try and advance understanding of long COVID and treatment of long COVID. And to summarize of the, by all means, I'd be very pleased if you go away and read the article, but to summarize what we said, we felt at the time very frustrated that there was a lot of counting of cases, but not much doing. And I think we had the line in it that we had to move from the observational to the interventional. And of course, moving from observation to intervention implies that you know how to intervene and that you have some kind of rationale for your intervention to actually do something useful. So in a sense, that's what the rest of this talk is about. So as I said, I'm speaking from the United Kingdom, and people may be aware that here what's happening is that there's a lot of debate and a lot of controversy at the moment about government policy, where there's talk about a kind of tolerance for ending our measures to limit COVID-19 cases, accepting that we'll move into a phase very rapidly where we'll have 100,000 new COVID-19 cases per day. And implicit in that depending on the figures, that we'll have something like 10 to 20,000 new long COVID cases per day. And because of the demographic of where those cases are spreading, that'll be particularly within our secondary schools and our universities. Sorry, I seem to have jumped. Hang on. That'll be particularly within our secondary schools and universities. And as I alluded to before, I think we're almost scared to address the enormity of the questions, because this really does have implications for our society, for our healthcare provision planning, for education, and certainly, again, trying not to be political here, but questions almost too big for our politicians to be able to address in the heat of battle. So we've seen many versions of this in the last few hours, so I won't dwell on this. This is one of the versions that I like of the symptom profile. It comes from a very good paper from another long COVID sufferer, from Hannah Davis and her colleagues at University College. But it makes the case, as you've seen in other people's slides, that you all know very well, that this is diverse and variable and multi-system and multi-organ. So let's agree on that and leave it at that. So how can I, as a professor of immunology, do anything to help to narrate the story, the pathophysiology of this massive phenomenon of a variable, fluctuating, relapsing and remitting set of symptoms affecting almost every part of the body? Yeah. So I think I mentioned before that try and see it from both sides of the table. Try and see both the devastated, desperate, impatient patient who's just had enough. So you're, on the one hand, you might be on one side of the table, you might be the desperate patient just really thinking, why won't anybody give me any answers? Or you might be on the other side of the table, you might be the junior doctor who's been told by your consultant that you're now in charge of the long COVID clinic, and you don't know what long COVID is. You were never taught anything about it in medical school. There's been no chapter on it in your general internal medicine textbook, and you haven't got a clue. All you see is a very, is panicked people on both sides of the table. So let me give you a metaphor from another disease, which I hope you won't find it labored. You might find it helpful. So imagine you are now that junior doctor sometime in the past, and you're sitting in your clinic, you're now the doctor, and a young woman comes in to see you, and the first time she comes to see you, she complains of breathlessness and wheezing and respiratory problems. And the next time she comes to see you, she's worried about her hair loss and her high fevers. And the next time she comes to see you, it's about her painful joints. And then another 3 months goes by, and she's got a whole new set of problems to do with her kidneys and blood in her urine. And another 3 months goes by, and you wonder what on earth is going on, because this time it's all about the rash on her face. And how can so many different things be going on? And is she really ill? And if so, what with? Or maybe she's just some kind of hypochondriac or attention seeker. And many people will have realized that what I'm talking about here is a person with lupus. So I hope you can see that the metaphor is of some value, because one disease process, one molecular mechanism, and all these different parts of the body affected. But if you missed that textbook chapter and didn't know the cause, you might think it was a crazy person, who had all these sort of different things apparently wrong with them. And so in the case of a disease like lupus, it's taken a very, very long time to decode the story. If you sort of eyeball this timeline from a paper about the history of lupus, over the last 1,500 years, we've gone from little understanding of the phenomena, and the cure was going to visit the shrine in France, to modern medicine, where there's a very good molecular medicine explanation of lupus as an autoimmune disease, and we'll come back to that in a moment. And so over the last 40, 50 years of appreciating that it's an autoimmune disease, where almost a single step, a faulty immune response making autoimmune antibodies to parts of your DNA and proteins complex to your DNA can lead to all of these diverse disease processes. Okay, so if I try and fast forward from that and think, well, if it took us 1,500 years to get that far on lupus, how are we going to fast track that into hopefully a year or less of research in long COVID? We've had various discussions of this before, but the kind of hypotheses that our lab put forward and others, both in that BMJ article and in the World Health Organization document, are all of the obvious, really. The thing that Betty mentioned about how many ACE2 positive cells in many organs in the body are affected, and there may simply be the thing that you see on MRI or on CT scans, scarring and fibrosis in different tissues, that hopefully gets better with time. A lot of interest in a coronavirus doing something it was never meant to do in the textbooks, that's setting up a kind of long-term persistent reservoir of infection. A lot of interest and some evidence for virus being present in the long term in the gut. And you can do that in different ways, both by looking at people who are being investigated, because of things like their inflammatory bowel disease anyway, or the other trick that we like is simply getting a poop sample and using a PCR to amplify virus out of poop and showing that many people do have it there persistently. What we don't yet know is whether that's a specific correlate of long COVID or just something that happens in some people after COVID. Oh, sorry, I've jumped again. We'll talk about another hypothesis that acute viral infections cause immune subsets, and we'll talk about that in a moment, to be perturbed and dysregulated. And then the last hypothesis that I'm rather keen on, and we and others have some evidence for, that we can think about long COVID as an autoimmune response, a bit like the example I gave from lupus. So let's explore some of those things. So I've now used the term autoimmunity quite a lot, and we all, I guess, vaguely understand what we mean by that, but just to kind of home in on it. So for folks like me, the immune system is a wondrous thing. It's not just a sort of single type of white blood cell. It's many thousands of different types and subsets of white blood cells that do things all around your body and obviously make products. The best known one are the antibodies. And the reason that they have such an enormous evolutionary value for all species is that they're the way that we fight unwanted invaders, whether it's viruses or bacteria or fungi or cancer cells. And we also have known for a long time that this very complex regulated immune program sometimes goes awry, so that instead of recognizing foreign targets, the jargon name for that is antigens, they start to recognize antigens on human cells, on your own cells. Examples like recognizing joint antigens leading to arthritis, or the myelin sheath of neurons leading to multiple sclerosis, or the cells that make insulin leading to type 1 diabetes. And the reason I think it's useful to know this and think about it in this way is that I think it does lead us to answers and therapeutics, because recent decades really have been a kind of golden age for autoimmunity research and for translating that research into understanding of mechanism and into many, many newly licensed drugs that have made a big difference to people. So you can see my direction of travel here, that if we could tell this story better, we could do things for people. So in the past, we've known of many examples where virus infections lead to long-term symptoms. And for my taste, if we can learn from these and define molecular mechanisms, we can design precise diagnostic tests for health service use And for all the reasons we've discussed this morning, that in itself would be a valuable thing, I think, because then people start to have a clear, unequivocal diagnosis that they can take to their hospital, to their doctor, to their employer for that matter, and start to negotiate what's going to happen next. But it's not just that, is it? Because if you knew, again, by analogy to any of those autoimmune diseases, what was causing it, you can then turn to that vast toolkit of goodies we've got for treating autoimmune diseases and begin to look at what one can do to get rid of those the symptoms. We've talked about some of these things. So we know the evidence for fibrosis. We've seen the MRI changes and CT changes, and we've seen the evidence that some people have persistent virus in their guts and in their poop. So just to tell the story of some of the bits of evidence from some of those other virus infections I was talking about. So one of the quotes that I've used, probably overused, is that acute viral infection can be like throwing a hand grenade into the immune system, dysregulating the normal immune subsets. One of the best examples of this that I've ever seen is glandular fever, the way that Epstein-Barr virus infects often young people, and they get glandular fever or infectious mononucleosis. And many of them are not just laid low by the acute infection, but it can take them years to get back to normal in terms of their state of health, their susceptibility to other infections. And there's an immune system explanation for that, because their immune system really has been hijacked here in terms of a kind of T cells called CD8 cells. Here's another example from another infection that's been mentioned today already, Ebola virus infection. We all know that Ebola causes acute disease and death from a kind of hemorrhagic illness. What I think fewer people know is that even among the survivors, there's a really high prevalence of, the kind of things that'll be familiar to you, headache, joint pain, muscle pain, memory loss, and a lot of work ongoing to try and understand that. So that's two examples from quite diverse viral infections. Here's one of my favorites. Our lab does a lot of work in Brazil. We work on an infection spread by mosquitoes called Chikungunya. The reason I bring up this analogy is because, again, it's not just the acute infection that troubles people, which is looks a bit like dengue or Zika. It's a fever and a rash. It's the fact that a sizable minority of people go on to get an autoimmune arthritis, and that devastates them. It puts them out of work. It puts them out of the economy. It also, in countries that are affected widely by it, like Brazil, affects pressure on the healthcare system. So you can see why I kind of bring up these examples. So these are the kind of examples that certainly in my lab and other immunology labs are informing the research that we're doing, working with people who have long COVID, to try and understand what on earth it's all about, therefore, and thus, what we can do for people. And to finish, this is an example of the kind of work, not from our lab here, but from Yale, from Akiko Iwazaki and Aaron Ring. And so this thing that looks like a kind of starry night, every time there's a dot lit up as a color, that's an antibody that bound to a human protein, in this case, either from central nervous system or from the vascular lining, showing you how, as a consequence of COVID-19, a whole new array of autoimmunity can be set up. And our mission at the moment, and I think the same in some other labs, is to try and tell that story and work out which autoimmune profiles could be responsible for long COVID, which we think will lead us to diagnostic tests and to therapeutics. So I think that's my last slide. So I'll end my slideshow there, and we'll probably revisit some of these things in questions.
Thank you very much, Danny.